Good day, ladies and gentlemen. Thank you for standing by, and welcome to today's presentation, Using Health IT to Improve Care Coordination and Outcomes in Patients with Complex Healthcare Needs. Your host today is Vera Rosenthal, Program Manager at Health IT Program at AHRQ. I would now like to turn the conference over to Ms. Rosenthal.
Thank you, Nathan. As Nathan said, I'm Vera Rosenthal with the Agency for Healthcare Research and Quality, and I would like to welcome you all to this webinar today titled Using Health IT to Improve Care Coordination and Outcomes in Patients with Complex Healthcare Needs. We're going to have 3 wonderful presentations today, followed by Q&A at the end. And as Nathan said, due to a large number of participants, we unfortunately cannot take questions over the phone, but you are more than welcome to submit them through the chat feature, both during the presentations as well as during the QA session. And just as a note, for more information about any of these projects or any other health IT activities at AHRQ, I invite you to visit our website, which is healthit.ahrq.gov. Next slide, please. Oh, never. And just to give you all a heads up, in order to provide CE credits for today's session, I'm required to tell you that neither me nor any of our presenters today have any conflicts of interest to report. So to get started with our first presenter, I'd like to introduce Dr. Elizabeth Siemens. She is a health services research scientist and the research director of the Center for Clinical Translational Research at the Billings Clinic in Billings, Montana. Dr. Siemens has considerable research experience in the fields of chronic disease management, palliative care, care transitions, and the use of complexity science-informed approaches to behavior change. She has published in peer-reviewed scientific journals in the areas of economic and clinical impacts of inpatient and home-based palliative care, nutritional status and malnutrition, health IT, diabetes management in rural and frontier communities, and the specific use of telehealth technology. Dr. Siemens, over to you.
Thanks, Vera, for that introduction, and welcome, everybody. So I'm going to talk about improving care transitions for the medically complex patient in rural Montana. As Vera mentioned, I am at Billings Clinic, which is an integrated system with a multi-specialty group practice and a 285-bed hospital, over 300 physicians, nurse practitioners, and PAs, level 2 trauma center, and probably most relevant to this presentation, 46% of our admissions come from rural communities. So our focus on improving the care for rural patients is relevant to our population. There we go. So just a little bit about the current state of affairs, which is probably very familiar to many of you. By 2020, it's projected that there will be 81 million patients with complex healthcare needs. 20% of Medicare patients are rehospitalized, and we know that 50% of those rehospitalized have not had any medical follow-up between the first hospitalization and the readmission. This costs Medicare a lot of money. Almost up to a quarter of patients suffer some type of adverse event, and more than a third of discharged patients do not know the names or the purpose of the medications they are on post-discharge. And finally, 75% of outpatient visits occur before the discharge summary arrives. So rural and outpatient primary care providers don't have the information they may need on their patients. So in response to this state of affairs, we created what we call the PIT Stop project, or the Patient Information Transfer System to Outpatient Providers. The objectives of our project were to improve health information transfer, the process of information transfer at hospital discharge, by improving communication both between providers, inpatient and outpatient providers, and their patients, as well as between the providers themselves. And then to achieve, especially at the time of transition of care, improved quality of care, patient safety, and efficient use of healthcare services. So our work was based on the chronic care model, and in particular, I'll draw your attention to delivery system design together with clinical information systems and how those two components interact to improve those productive interactions between patients and providers or care teams. So our study design, originally was an 18-month prospective controlled intervention study, but it ended up within a 4-year project period with about 1,200 study participants, and involved our Billings Clinic Hospital and over 100 regional rural primary care clinics. And I will show you where they are in a minute. So we focused on medically complex patients because those patients are most at risk for readmission. So patients needed to have at least 2 of these conditions: diabetes, heart failure, stroke, COPD, coronary artery disease, hypertension, depression. Needed adults discharged from our hospital and living in a rural Montana community. And actually, we included our whole service area, so we also included northern Wyoming and western North Dakota. So our intervention had 3 major components. First, we created a primary care provider discharge notification. So, as I said in the background, that 75% of follow-up visits were occurring before the discharge summary reached the primary care provider. This was a way to immediately notify primary care providers of their patients who've been in the hospital. So, and I'll show you an example of what this looks like as well. But, basic information: your patient was in the hospital, where to go for more information, and eventually it was automatically faxed at time of discharge to the primary care provider noted in the patient's electronic health record. Just to mention, our electronic health record is Cerner. So when you see the screens, they may or may not look familiar. Then we also standardized our house-wide discharge process, and we used some Lean Six Sigma approaches to do this, and created a discharge checklist as well as standardized patient education information. What we found out is that discharges were happening in all different ways across the hospital, and patients were also being given different information. Patients with the same discharge diagnosis were receiving different information about their condition and different instructions, etc. To do this, we did not just do this ourselves and then, push it in on everyone. We got our admission, discharge, and transfer nurses together, and that's a special classification of nurses who really are responsible for most of the discharges that occur. So from all the hospital units, they sat together, mapped out kind of the current processes, and figured out what could be standardized, given that some things do need to be different on different units. And then the final piece of the intervention was nurse-initiated patient callbacks. So before a patient leaves the hospital, a telephone call is arranged with that patient, usually 2 days following, but depending on the needs of the patient. So we schedule it with the patient, and then that person is the person that calls them back. So it's somebody that they know. It's the nurse that discharged them, and that's been effective as well. So this is what the PCP discharge notification looks like. Basically, dear doctor, thank you for letting me take care of your patient. Here's where you can go. And so it says, for further information, go to billingsclinicdoc.org, which is our provider portal. So they can go to the portal, look up the patient, and find the full record, see the full record. And then also we included information on scheduled follow-up appointments, which we also tried to schedule more often, even for rural clinics, improve those processes as well, so that patients were more likely to leave the hospital with a scheduled follow-up appointment, as well as the medication list, current medications, pending medications, and a number to call. The other, this is the discharge checklist that I mentioned as a second piece of our intervention. And this is what the ADT nurses came up with as what we could standardize in terms of what has to happen at discharge. So they go through the list. The little pencil on the right will take them right into the record. You can complete what they need to do. And then all this information is fed into that notification that you just saw. So when follow-up appointments are scheduled, they are fed into that notification as well as medications, etc. Okay, so the outcomes we were interested in, clinical and healthcare utilization outcomes of improved accuracy of our patient-friendly medication list, improving the accuracy of patients taking their medications correctly, some utilization measures of readmissions, emergent care visits, then at a system level, increasing the follow-up appointments within 30 days, improving that communication with between primary care providers, improving workflow processes, and then improving the satisfaction of providers and patients. So here's our sort of intervention timeline. Now, I know in the beginning I mentioned a single intervention. We added a few more. Mostly what I'm going to report on in the results, I think I can use one of these things, are these first two, the baseline and first intervention. These other two interventions, this was a more fully automated discharge notification process, and then intervention 3 was we added a medication reconciliation process. So because we had those different intervention points, we continued to interview patients, and we're able to look at some of our outcomes over time, which I'll show you in a minute. You can see we had, as I mentioned, the 400 sort of pre-post patients, and then we had fewer in these time periods they were interviewed. They were interviewed by telephone. So these are the patient characteristics by study group. We have the baseline and the intervention group. That's that first intervention I mentioned. They looked fairly similar. We had more patients in the intervention group with hypertension and with depression, which actually should hurt us in terms of our outcomes. So those patients are sicker and might be more likely to be readmitted, et cetera. But in any case, we did use those as predictors to see if there was an independent effect of those of having hypertension or having depression, and we didn't find anything there. And then chronic conditions were the same. And then going along with having more patients with some of these chronic conditions, they were on more medications in the intervention group. So the baseline group, 7.8 average medications, and 9.8 in the intervention group, a significant difference. But again, that should work against us in terms of what we're looking at for outcomes. So here's the map that I promised to help you. Let's see. This is Montana. So that's where we are, and this is Billings right there. Down here is Yellowstone National Park for you outdoor enthusiasts, and up here in the upper left-hand corner, this is Glacier National Park. But as you can see, patients are coming from all over the state, mostly the eastern part of the state, quite a few from northern Wyoming, and some up here from the western part of North Dakota. So there's a wide range of travel of patients, and these are the patients that were in our study. So the results, one of the things we're trying to improve is we saw that patients were being readmitted and were not without any type of follow-up. So in this slide, you can see we looked at 30-day, we looked at 30-day primary care visits and saw a significant increase from baseline to intervention. We also looked at 14-day PCP visits, but then we decided, well, let's look at any healthcare provider, because often patients don't see their PCP, but they see their cardiologist. And that's actually where we saw the largest increase when we included PCPs plus any other providers. As I mentioned, we can, because we have these other intervention points, we could look over time. This is that same outcome of follow-up visits, and we continue to see an increase past that initial increase that I mentioned, which is right here. We continue to see the increase in the next two time periods. In terms of readmissions, it was difficult for us to just look at well, the overall readmission rate wouldn't be relevant because we were really looking at a subset of the population, and it was difficult to look at readmissions just among them. But so what we did is we looked at if you had a visit or if you did not have a visit, what was your readmission rate? So those who had the 30-day medical visit, their readmission rate was 2.9% versus no visit at 7%. So not having a visit increased your odds of a readmission about 2.5 times. So that, although we didn't have an impact on the overall readmission rate, we felt like this was moving in the right direction, that having a 30-day follow-up appointment was influencing the fewer readmissions. In terms of medical education, again, we're looking over time at the 4 time periods, and not surprisingly, because one of our interventions specifically was some of the follow-up phone calls, that is where we saw the significant improvement from baseline to over time. And that wasn't implemented until about here. And we saw more patients reporting that they had received some type of medication education by phone, and even in the hospital we saw trending towards improvement on medical education. The type of medication education that was received also increased over time, and things like being educated on why they were taking what the medications were for, what the side effects were, any special instructions, and we saw improvements across the board there. And then finally, provider and patient satisfaction. So this slide shows provider satisfaction, which improved, either trended or did improve between the baseline and the intervention. And just for an example, the first question, the care transition process for patients discharged from the hospital to the rural outpatient setting is efficient and reliable and results in quality patient care. And that's where we saw the largest increase of providers who either always or usually agreed with that statement. For patients, this is the patient self-report on these questions here on the left. And while these were not statistically significant improvements, what I did do is put a delta here on the right. So they were mostly positive changes. Often we started pretty high, so it's hard to see that kind of change, but at least we were seeing things trending, for the most part, in the right direction. So in conclusion, a health IT intervention that's focused on the discharge standardization and improved communication for providers may improve follow-up for medically complex patients and potentially leading to reduced readmissions. There are clinical and financial implications given CMS's reimbursement adjustments that we're all familiar with for avoidable readmissions. This may be a model for patient-centered medical homes and accountable care organizations as we're sharing the costs for these patients, where that communication between the hospital and the outpatient clinic is key. And these are low-risk interventions. There's nothing really to lose by improving the communication and between providers and with patients. So we should encourage dissemination. I think either AHRQ or Academy Health has often asked for the value to the customer, so we can think of two types of customers here. The regional or rural primary care providers receive value in getting this information regarding their patients. When we started the study, we traveled out to probably 10 rural clinics, and we just asked them, what issues they had and what did they think about care transitions. And what they said was, we don't even know our patients have been in the hospital. The first time we find out they've been in the hospital is when they show up, really sick at our office or in our little critical access hospital. So they really were wanting that information. And then the value to the customer of the patients is just an improved discharge process, receiving more standardized information, having more time to spend talking to their nurses and receiving education, and also receiving that follow-up by phone. And if you have any questions or anything further, we will, have questions at the end, but you can also contact me directly at this number. And now I'm going to pass it over to Vera for the next presenter. Thank you very much.
Thanks, Dr. Siemens, for that wonderful presentation. So our next presenter is Dr. Penny Feldman. She is the Senior Vice President for Research and Evaluation at the Visiting Nurse Service of New York and currently leads the Visiting Nurse Services Research Center and its portfolio of externally funded research projects. These projects are designed to assess the effectiveness and cost-effectiveness of interventions. Several of them are IT-related to improve the quality of care and health outcomes of low-income disparity populations, who comprise over half of the patient population. Dr. Feldman is a former faculty member at Harvard and is currently an associate professor at Cornell Medical College. And over to you.
Great. Thank you very much, Vera. And again, thank you all for participating in this webinar. As Vera mentioned, I'm at the Visiting Nurse Service of New York. We're an integrated delivery system. We grew out of what was a traditional visiting nurse service. We now serve about between 130 and 140,000 unduplicated patients each year in our home health division. We also have about 35,000 enrollees in managed long-term care and managed care plans, and we have a hospice and various other programs. The study that I'm going to talk to you about today is a comparative effectiveness study, also focused on this really challenging issue of medication management among complex patients, and particularly as they transition from one setting to another. I don't think I need really to talk through this background slide, but to say that, most of our patients have multiple comorbidities, a high number of medications, and the literature is replete with evidence that shows the association between the number of medications anyway and medication adherence issues. And there's also a little bit of work on the relationship between medication complexity, even controlling for a number of medications and chronic conditions, and its relationship to unplanned hospitalizations and ED visits. We conducted a randomized study to examine, relative to usual home health care, the effectiveness of an electronic clinical decision support system. I'm going to use CDS as I speak, so hang on to that, CDS, Clinical Decision Support Intervention, to improve the medication management and the outcomes of patients with complex medication regimens who were entering our home health care division as new patients. And our aims, or the aims that I'm going to talk about today, were to examine and assess nurses' use of the CDS and then patient outcomes. As I mentioned, we randomized at the nurse level. If you look at the bullet at the very bottom of this slide, patient group assignment was based on the nurse who was, what we did was we electronically identified eligible patients for this study based on their medication complexity. And as soon as a nurse's first patient was judged eligible, the nurse was randomized into either an intervention or control group, and then all of the nurse's patients after that were obviously in the same group, and intervention or control, depending on the time on the nurse's initial randomization status. And in that way, we prevented contamination so that a nurse wouldn't have patients, some patients exposed to the intervention and some not. The nurses received, for all patients who had high medication complexity, and I'll explain in a bit what we meant by that, a clinical alert, actually an email on their their iPad. It's not an iPad, excuse me, but it's a tablet-based computer that all nurses use in the field. We've had an electronic medical record for many years. So they got an email alert that they had a particular patient with high medication complexity, and then the alert, as you'll see in a moment, indicated to the nurse where she could go on her tablet in the electronic medical record to actually access a specific, they call them problems in the lingo of our organization, but it's essentially a tool to help the nurse manage a patient with a particular condition or situation, and in this situation it was medication complexity. And the nurse also received patient educational material to give to the nurse. So, and I just talked about the randomization. This is actually a picture of the alert as it showed up on the nurse's tablet, and you see it identified a particular patient, Jane Doe, and it explained that medication complexity really could derive from the number of doses a day that a patient had, from the number of different routes of medication, by which we meant through an inhalant, injectable, or oral, and special instructions that the patient might not need to remember. So, for example, take it with meal, don't take it with a meal, lie down afterwards, don't lie down, you know, the myriad of instructions that come along. And all of that data was actually contained within our electronic medication database. We actually use something called First Data Bank, which is one of the nationally commercial medication databases, and that provides all the information for us. And then, as I said, we directed the nurse to the medication complexity module on her EMR. The CDS tool was only triggered if a patient on a nurse's caseload had high medication complexity, which we defined as patients in the top 20 percentile and above of medication complexity, and we chose that cutoff point because earlier work that we had done showed that was where risk of hospitalization and ED use had significantly increased. The care management tool was made available after the second visit because that's sort of the time by which the medications and so forth have been reconciled and settled down for the patient. And the CDS tool was really structured in exactly the way all of the other clinical decision support tools on the nurse's tablet are structured. So what she saw looked very much like what she would see for someone with heart failure or COPD or whatever. We established medication eligibility by we identified newly entered home care patients. We automated this medication regimen index, and the cutoff of 24.5 or higher, that was really the cutoff of the 20th percentile or greater medication complexity. And as I mentioned, the algorithm is based on frequency, administration, and instructions. We adapted it from work that had been done by George et al. You can see the reference at the bottom of the slide. They're an Australian group. They had done a handheld kind of Mercy calculation, and we automated it, installed it within our EMR, and had the alerts triggered off of that. And we also were able to incorporate over-the-counter medications because those were all included in our electronic medication database as well. And then we had medication and assessment data that were collected as part of usual care and were documented in the patient's EHR. We did an intent to treat analysis in the first place where we compared patient outcomes between patients whose nurses were randomized to the CDS or just were randomized to remain in usual care. And then we also, and you'll see this later, we also did a within-group sub-analysis of the nurses and the patients who were, in fact, randomized to the CDS tool because we wanted to understand better what nurse and patient characteristics were associated with use of the CDS, and also what was the association between using the CDS and the patient outcomes. This is our consort diagram. We actually, we randomized on a 2-to-1 basis so that there were 2 nurses randomized to usual care for every nurse that we randomized into the intervention group, and so we ended up with, with about 500 randomized nurses and a large number of patients associated with those nurses. And if you go all the way down to the bottom of the consort diagram on the right-hand side, you can see that about 40% of the patients actually had the CDS tool used on them, and about 60% of patients did not. We'll talk more about that later. I'm going to first show you the results of the intent to treat analysis. We examined the reduction in medication complexity, and we looked at it a number of ways, but we had decided that our dependent variable would be a dichotomous variable of either you got below that high complexity threshold or not as a result of being treated by an intervention nurse. And then we looked at ED use and hospitalization, and we used logistic regressions in which we controlled both for patient and nurse characteristics. We controlled for nurse clustering, and we used logistic regressions to predict the 3 outcomes that I just mentioned. This set of bar graphs is what every researcher does not want to see in a comparative analysis study. You know, we do our research because we want to find the answer, but needless to say, we're working on the hypothesis that an intervention is going to make a difference. And if you go from left to right on this slide, you can see that roughly 6% of both the intervention and control patients saw a reduction in their complexity score. There was no difference. About 16 to 17% ended up using the ED during the time they were in, their home health care episode, and between 20 and 21% were hospitalized. And so we actually did not see any result of our combination of our electronic alert and directing the nurse to this clinical decision support system. So pretty devastating. We did very much want to understand what was going on and what the predictors were of a nurse using or not using the CDS tool. And we could only look at this by focusing on this subgroup analysis within the intervention group, because the control group never had the opportunity. They were never even exposed, so they didn't have discretion. But, this CDS tool was not something that was locked into the system whereby you couldn't get out of the system unless you used it. This was a discretionary tool that the clinicians could use, as are the other problems built into our electronic medical record. And so we wanted to understand what was really going on inside the intervention group, and we had the hunch that one of the reasons that we didn't see a significant difference was that not every nurse used the tool on every patient. And so to do this subgroup analysis, we used a method called propensity scores, which is essentially we assigned a score to each nurse within the intervention group that represented her likelihood of actually having used the thing once exposed to it, controlling for those differences that we could measure between users and non-users. And then we used the propensity scores as covariates in logistical regression models to estimate, this says effect, but again, it's only the association of if a nurse controlling for a variety of things actually used the CDS, did that make a difference? Or did it seem to be hopeless altogether? So about 8 out of 10 of our intervention nurses actually did use the CDS. That was about 135 out of the 165 nurses exposed to the intervention. But they used it for only 42% of their patients. So for just about 1,075 patients out of the 2,550 high medication complexity patients for whom they received an alert. And we looked at the nurse characteristics here, and we were kind of surprised, but our older nurses were actually more likely to use the tool controlling for other things. Sometimes people think that younger nurses are more likely to be comfortable with technology. We didn't find that. We found that nurses, again, controlling for other things who had worked for us for a longer period of time were more likely to use it. And nurses who had more patients in the study, that is, who were triggered more times. So it does suggest that familiarity may have increased the propensity to use it. We also, many home health care organizations that have very large patient populations, and we are the largest nonprofit in the country, often use a mix of salaried nurses and nurses who are called per diem. They're really paid on a per visit basis. And we did find, and in this we were not surprised, that our salaried nurses were more likely to use it than our per diem nurses, presumably because the per diem nurses are just anxious to go, to gin up more visits because they get paid on a per visit basis, whereas a salaried nurse, although she has productivity standards to meet, doesn't have that financial incentive to move quickly through the patients. We also looked at patient characteristics here, and we noted that patients that nurses were more likely to use the CDS tool for patients who had more medications. For patients who had some of these conditions like hypertension, cardiac conditions, stroke, dyspnea, and we have no hypothesis even after the fact exactly about why that's the case. But nurses did use the tool for patients who were in care longer, which we think probably meant that they had more time in which to use it, and for patients who had more RN visits. Now, they were less likely to use it for our Medicaid African American patients, and that certainly set up an alarm bell for us, which we're examining, but they also were less likely to use it for our private insurance patients. So it was really the Medicare patients for whom they were more likely to use it. And again, we're not really sure what's going on there. We will explore it. We do think they were less likely to use it for cancer patients, and nurses did tell us that they felt that, most cancer patients were in active chemotherapy. They really did not want to mess with the patient's medications. Patients with more chronic conditions, as distinct from more medications, which, again, probably made the nurse feel that there was so much going on that it was more complicated to try to address complexity in this context. And then patients for whom there was a change in the patient's primary nurse, which is called the coordinator of care. When we looked, again, within this intervention group to just see, controlling for what we can control for using this propensity score process, did use seem to make a difference? We discovered that, in fact, patients for whom the nurse used the tool were significantly more likely to have a reduction in complexity. There was no particular difference in ED use, but they were also significantly less likely to be hospitalized. So it suggests that if you used it, it made a difference, but there were simply not enough patients for whom this was being used to make a difference in our overall intent to treat analysis. So this is, really food for thought for our next work. As for conclusions, I've just repeated the intent to treat analysis did not find an intervention effect, and I've suggested that we think that this has to do with the fact that it didn't penetrate very heavily into the population, that it did seem to make a difference for the patients for whom it was used. And there were some potentially remediable factors or points where one could intervene. For example, the use of per diem versus staff nurses, attempting to improve continuity of care so that there were fewer changes in the primary nurse, the nurse coordinator of the patient, and the issue around length of stay. And often there's not a lot of discretion around length of stay because a managed care organization, for example, is determining the patient's length of stay, but there are probably issues around better managing resources and short lengths of stay. There's actually very limited research out there that really examines nurses' CDS use or the impact on patient outcomes. There's a big literature on kind of alerts and computerized medication prescription systems with physicians, but nothing really on this, very little in this area with regard to our nursing population or tying it up with patient outcomes. And our findings do suggest that improving continuity of care, better managing short lengths of stay, as I said, and working to increase nurses' knowledge, comfort, and motivation to use IT, especially per diem nurses, could make a big difference. And something else that I didn't mention here, but is this whole signal to noise ratio, which we know increasingly with all of the electronic alerts that are bombarding clinicians, and that's true for our own clinicians as well, that this is something we also have to look at, because there were a lot of other things going on that nurses really had to pay attention to in addition to medication complexity. We sat back and asked, finally, this is my last slide, what did we learn? What did we wish we had done? And we really did not build into this study a lot of pre-intervention nurse engagement or development. In the prior study, you saw the use of Six Sigma and so forth, and we really leapt into a randomized trial. And I think we didn't have enough of a foundation to really understand at the current time how our nurses were using CDS in general, what their competing priorities were, the circumstances under which they would be most likely to reach out to a physician, specifically about a change in medication. And so I think we felt that if we had done a great deal more groundwork at the beginning, we could have probably structured the intervention in a way that we would have had more penetration in the population with hypothetically more powerful results in our intent to treat analysis. So I did want to acknowledge we had a superb team working with us, and you see them acknowledged here. I think actually Margaret McDonald, our study director, is probably on the phone somewhere out among you. And at this point, I am going to turn the chair, if you will, back to Vera and Eric.
Thank you, Dr. Feldman. For our last, but certainly not least presentation, I'd like to introduce Dr. Eric Eisenstein. Dr. Eisenstein is an associate professor of medicine in the Division of Cardiology at Duke University. He is an established researcher in outcomes research with special expertise in the use of large databases to assess the clinical and economic outcomes of patients. His presentation will describe a clinical trial that used information interventions to facilitate care transitions for North Carolina Medicaid beneficiaries. Dr. Eisenstein, over to you.
Vera, thank you. I'd like to begin, though, by acknowledging the work of David Lobachen. Some of you might know David. He retired from Duke a couple of years ago, but Duke was the leader of our clinical research and informatics team at Duke here, and then he was the PI for the first 3 years of the study. I want to thank David for all of his work, for his mentorship of our team, thank the members of the team, and also the agency for their support of this project. Our goal in this project was really to determine whether clinical decision support messaging would be able to facilitate care transitions for patients with complex medical conditions. And the patients we're looking at are patients within our Medicaid patients within our network. And then the transitions we're looking at are patients going from the hospital, from the ER visit, from specialty care, all back to their own medical home. And within this, our objectives were, first of all, to really increase our knowledge regarding how decision support could be used in managing this vulnerable population with chronic illnesses. Secondly, and we're going to talk about that today, is to assess whether decision support impacted, first of all, the coordination of care for these individuals, and secondly, whether that had an impact upon healthcare resource use and medical costs. And then if we were successful, we hoped that we could demonstrate a generalizable approach that could be replicated in other settings. And so our population for this study was drawn from our network. As I said, North Carolina has 14 Medicaid networks. Ours is one of them. It's called the Northern Piedmont Community Care Network. At the time of this study, and there's an error, this is an old set of slides. This is not my current set of slides we're looking at. But at the time of this study, we were serving 49,000 Medicaid beneficiaries in a six-county area. And our network included not just all the hospitals, the county hospitals, and the Duke hospitals in our network, but also included the different physician practices, the various government organizations that are concerned with the care of these patients, and also a care management team. And our care management team was a multidisciplinary team tasked with the coordination of care for individuals of these Medicaid patients in our network. And we thought that if we're looking at transitions of care, there were two kinds of services provided by our care managers that might be very useful. And the first of those were assistance with keeping and with making and keeping appointments. As we talked about earlier on earlier presenters, that first appointment coming out of that in that transition of care. And then secondly, support for obtaining and taking medications. To be enrolled in this study, patients had to be continuously enrolled in our network, our Medicaid network, during our intervention period, which is the year from February of 2011 through January of 2012. Then we had additional 6 months of follow-up. We identified complex patients using claims data. We used criteria that were published by HEDIS, looking for patients with different chronic conditions. I'll show you those on the next slide. But then we modified those to include medications from the definition of chronic conditions so as to avoid biases in selecting more adherent versus less adherent patients. We also found that the criteria of HEDIS were not effective in identifying persistent asthma patients. We actually reviewed charts in order to determine that particular kind of chronic patient. So in order to be included in our study, you had to have meet one of five standards. First of all, you could have 2 or more Institute of Medicine priority conditions, and those are shown here. Or you could have moderate to severe mental health diagnosis, and those are shown here. Or you could have chronic renal disease, end-stage renal disease, or sickle cell disease. And so these are the 5 groups of patients that are included in our study population. We benefit from the fact that within our network, which was established in the late 1990s, we had already developed a robust regional health information exchange and data repository, which was actually built to allow the communication between the different people in our managed care networks and allow them to share in the management of these patients. So patient information was collected through 3 primary channels. First of all, the managers, the different care managers, documented their care plans, documented their interactions with the patients, and documented the services that they gave to these patients. We also had automated transfer of data between our network members. So our database included appointments made and missed, people getting into hospital or not, and different things of that sort. And all that information was also available to our care managers. We also got monthly data feeds from the North Carolina Medicaid office, which told us who was enrolled in our system. We had billing data that we could begin to look at costs, at least the cost to Medicaid for these patients. And we could also look at different kinds of events that happen in those patients' lives. And lastly, they gave us complete pharmacy data for these patients. Along with developing the data repository, we also had experience with a asynchronous clinical decision support system, which actually ran on top of our system, and nightly it kicked off rules engines. And so these rules engines were, these rules knowledge modules were really designed to look at instances of what we called inappropriate care, or in this grant we're calling targeted patient care. So for instance, if we knew that a child was supposed to have a visit, a well child visit, either that visit wasn't scheduled or they actually missed an appointment that was scheduled, that information would then be kicked back to the care manager. They could then send through it was an email notice going back to the care manager that they had missed that visit, and then the care manager would then be in contact with the patient, or we could be in contact with their medical home. For this particular study, we had designed it as a randomized trial. We had planned it to be allocated 1-to-1-to-1 by family units, so all people in the family were in the same treatment group. And we had a usual care group and then 2 intervention groups. And so the reports group had 3 kinds of interventions in it. First of all, what we call the care event summary report. And this would be a report that would be faxed from us at the central office to the patient's medical home. That would contain information that would be available in their discharge summary. It would contain information about appointments that the patient had made or appointments that the patient should make after being discharged. We also sent letters to the patients. The letters to the patients contained information similar to that which had been sent to the clinics. It contained discharge information, listed their appointments, suggested if they didn't have one, they probably would like to make them, gave them the contact information, and then told them what information they should bring to that visit. And then thirdly, we issued a release of information request from the care transition location on behalf of the patient's medical home. So those 3 interventions were the reports. And then for the Reports Plus group, they got all those interventions in the Reports group, plus we sent an email to the care manager who was responsible for the coordination of care for these patients, telling them that a transition had occurred and allowing them to get involved with the facilitation of this transition. When we began planning this study, after receiving the grant and began planning, the state of North Carolina Medicaid, like a lot of Medicaid organizations and states around the U.S., began to experience some difficulties, financial difficulties. And they began to implement programs to look at reducing the admissions and the expenditures for hospital admissions within their patients. And so there were two design changes that were made in this study. Let me go back to the previous slide now, go over those quickly. The first one was that our network, our local network, requested that instead of having a 1-to-1-to-1 allocation, to have a 1-to-1-to-2 allocation. So that meant that the Reports Plus group, half the patients were randomized there, 1/4 were in usual care, and 1/4 were in the other group, the basic reports group. So that was the first thing that happened. And then secondarily, after that, they came back to us, and because there was an emphasis on hospitalizations, they asked us to also send, whether they were patients randomized to usual care, reports, or reports plus, to send email notices to the care manager whenever the patient was admitted to a hospital and then when they were discharged to a hospital. So that also had an effect upon the intervention of the plan. Fortunately, in this network, or in our study, most of the transitions were ER visits. Secondarily, they were transitions from specialist care. We actually had very few hospitalizations, so the effect of that wasn't as great as one might have thought upon our study. Nonetheless, we had to change our design for our study. And then as we got into the study, we found out that there were some sites that were already receiving automatic transmissions from their hospitals. And so they asked us that we not send information for those sites. But those were very few sites in our study. Looking at our randomization pattern of patients, you can see we're now looking at dual eligibles versus straight Medicaid. And if you look at the dual eligible patients, you can see here we had about 400 patients in each of our group. By the way, and I should have mentioned this earlier, the changes that were requested by the state were only for the straight Medicaid patients. They weren't for the dual eligible patients. So both of those changes were related to straight Medicaid. So you can see in the dual eligible here we have about 400 patients per group, a little less than 1,300 patients enrolled there. In our straight Medicaid, once again, we have twice as many people in reports as in the controls, in reports plus rather, as in the other two groups. That's about 7,000 there, and a total of about 8,400 patients randomized in our study. Our network is basically moms and kids. If you look at the previous work we have published, you can see that it's overwhelmingly female, and about over 50% to say 60% of the people are under 21 years of age. Because we're looking at chronic conditions, in this particular study, the population is a little bit different. You see, we still have 60% female, 65% African American, which is standard for our network. But the age distribution is moving to a little bit older. You see here only a little over 45% of the patients were under 21 years of age. We now have another 45% plus who are 21 to 64 years of age. And then 5 to 10% of the group patients in each of our treatment group were actually greater than 65 years of age. And looking at the diagnoses or the reasons that they were chronic disease patients, you see that almost half of the patients, or 45%, had a mental health diagnosis as the reason they were considered chronic patients in our study. About a third of the patients had hypertension. About 1 in 5 had diabetes, and all the other chronic conditions were less than 1 in 10. This slide shows the information interventions generated and then sent in our system. I'm going to go over this in a little bit of detail. So the first line there shows that for the reports, and these would be reports generated for the reports group and the reports plus group. Our policy was to generate interventions for all patients every time a patient transition occurred. We only sent those if the patients were randomized to receive those interventions. So you can see for the control group on the first one there, we actually requested 4,500 sets of reports, but we only actually sent the notice or triggered the intervention in none of those patients. You can see that for the reports group, it's 4,500. We sent all of those except for a few missing addresses of patients and somewhere in the reports plus group. Going down to the arms for the email notices to the care managers, you can see that in the control groups, we only triggered 3,700 interventions. And so these are less than in the reports group because we didn't have email notifications for specialist visits. Only generated email notices to care managers for hospitalizations and for ER discharges. That's the reason that those numbers are a little bit less than the reports. And you can see in the parentheses on the right, for the controls, we generated 600 emails telling care managers that people that were actually randomized to controls were in straight Medicaid, and they had either been admitted or discharged from the hospital. So the number of admissions and discharges for straight Medicaid patients wasn't that high. You can see also that on the top there, that 4,500 for controls, the number of reports requested was our events that were triggered was actually about 2 for every patient in this trial. So going down to looking at, do we have an effect upon outcomes in this study? So looking at the care manager contacts, you can see that in the control groups we had about 1.2 care manager contacts per patient in the entire study. But although the difference of 1.3 for the reports plus group was significant, had p-value less than 0.01, one might question whether it was a clinically meaningful difference. And if you looked at the kinds of care differences that occurred, people in the reports group plus group tend to have fewer hospital visits, care managers going to the hospital, a lot more calls on the phone. So probably it was increased phone usage back to the patients that was causing that difference there. But there were no differences in other kinds of care manager contact. Looking at the hard outcomes, the clinical and economic outcomes, and I'm glad that Penny gave hers first because our results are somewhat like hers. We had no treatment-related overall differences in outcomes. I'm not showing the outpatient visits here, but looking at the ER visits, we had about 1.1 ER visits per patient during our study period. I believe that half of our patients did not go to the ED, so actually that 1.1 is spread across, and means actually 2+ hospitalizations for the other half of the patients. We only had 0.2 hospitalizations, though, for a patient in our study. So most of the action was in the ER visits, and then secondarily in the specialist visits. Looking at the medical costs, we had no treatment-related differences in medical costs for outpatient care, ER visits, and hospitalizations. We did, however, find about a $300 increase per patient in the reports plus versus the control group for pharmaceutical usage. And as you might recall, one of the duties of the care manager was to help the patients with their medication management. So we think this is likely due to the interventions of the care managers, and so there was actually more medication usage, which was associated with a greater increase in medication costs. Although we had a $400 increase in total medical costs per patient during the study period, that was a non-significant difference, p-value of 0.09. We also performed assessments to look at the fidelity of the information to see how well it had actually been delivered at the different sites in our study. And the first thing we did, we had for each of our study sites or clinics that were involved in our study, we visited them at 4 times. We had 4 regularly scheduled visits throughout our study period and audited up to 10 charts during each visit. And our purpose was to determine whether the intervention materials, those reports, were actually in the patient's chart and available to the care provider at the time of the encounter. And we found that overall, the materials were in charts about 60% of the time. Now, this was not 60% across all clinics. We found that it really was varied by clinic. Some clinics was in there 90%, 100% of the time, and some clinics not at all. So really there was a variation by clinic. Although we had performed extensive workflow analytic work and talk workflow through with each of the 35 study sites, some of them seemed to integrate these faxes and other kinds of information more easily into their workflow than others did. We had a lot of questions of the providers, both the qualitative and quantitative, collecting information from the providers. Generally, most of the evaluations were favorable, but we also found that the evaluations tend to correlate with our chart audit results. In other words, if the information was in the chart when the patient showed up for the visit, they liked the intervention. and if it was not in the chart, they tended to not like the intervention. We also were concerned about whether the recommendations when the patients were discharged from the hospital were actually being acted upon by the medical home of the patient. And so we did a post-discharge care audit of 600 patients. We found 156 procedures recommended for 87 patients, and 2 physicians independently looked at those recommendations. They believed that only about a third of those were actually necessary. And then we looked at the billing data. We found that about 2/3 of those had actually been completed by the patient's medical home. So looking at what happened in our study, I think I can make the case that we demonstrated that the decision support facilitated care transition process through the targeted use of information interventions. However, we actually had no treatment effect upon the major outcomes except for the pharmaceutical costs of the patients in our study. And so looking at the potential reasons why this might have happened, one is, as we said, discharge summary information was only available for 60% of patients at their primary care visit. And so the question is, if that would have been 70%, 80%, 90%, would the treatment of effect have been greater? I'm tending to say no, because we really didn't see any signal here. So if we had just increased the percentage, I seriously doubt that we would have had great differences in the effects upon either resource use, clinical outcomes, or cost outcomes of patients. The second question relates to, did the study designs requested by state Medicare really have an effect upon our treatments or our ability to deliver our treatments, which are our information interventions? And I think if you look at that, we're only talking about, they really only affected, although they affected the number of people in different treatment groups, they really only affected hospitalizations, which were really a minor part of the care transitions occurring in our system. And so they would not have an effect and so their effect would be very small. And secondly, we did a subgroup analysis looking at straight Medicaid patients and dual eligible patients and found no difference. So I really think that the design differences really didn't have much effect upon the outcomes in our study. So what was going on? And I think that you can make the case that despite some implementation issues, it does appear that the information interventions we had generally performed as we thought they would. We identified the correct patients. We sent out the information as requested. We sent letters to patients. We sent release of information to the hospitals and clinics. We sent discharge summary information to the medical home. We know that all that information arrived. It was either faxed or mailed, and we know that it all got there. 60% of the time at the clinics, it got into the patient charts, and we know that all the information went to the care manager. So that part worked. So what didn't work? And I would like to suggest just as a possibility that perhaps the issue is not the fact of the information, it's just the fact that the caregivers did not have the protocols or tools that allow them to use this information in an effective way to change the behaviors of patients, which then might have an effect upon their outcomes. And I want to close with this one slide, and I'll turn it back to Vera afterwards. And this slide is what we call our biomedical informatics value chain. So if you start here on the left-hand side, our new healthcare IIT idea was to use clinical decision support systems to facilitate transitions of care for patients with chronic illnesses. And so under the formative evaluation, you look at there the patient plus information resource. So we modified the relationships between patients and information resources and introduced new information resources. That was successful. We then produced information interventions. We produced, and we talked about those in the reports group, and then in the reports group plus group, we also had email notices going to the care managers. So that part worked. Going to the next area there, looking at the care processes, we have some evidence that generally, and except for the 60% of time, or the 40% of time that the discharge summaries were not in the charts, generally the rest of the care processes worked well. It's just that all this effort did not really have an effect upon clinical outcomes or economic outcomes of patients. So I'll close with this question. So I'm interested in what the people in the audience think. Is it really the fact of the information intervention, or the fact that, and I would say so many information interventions fail in healthcare, the fact that the healthcare providers do not have effective ways of using the information that they are getting. So I'd like to close that with that and turn it back to Vera. Thank you for your time.
Thank you, Dr. Eisenstein. In the interest of time, I'm going to jump right into the questions that we received during the presentations. Dr. Siemens, I'm going to start with you. I'm going to put the first two together because they seem to be more clarifying than, in depth. The first one is for your study for Montana. How did you define patients as rural? And the second one is, when actually does the discharge notification go to the PCP? What CIS action triggers that send out?
Okay, sure. I've answered all these questions in the chat, but I'm assuming you're thinking others might want to hear the answers as well. I've been busy. I think I missed most of Penny's presentation because I was answering all these questions. So Yellowstone County is the only county in the state of Montana that's considered rural, and that's with a population of 150,000 people. The rural designation is a federal designation based on density, so persons per square mile, the distance to the nearest service or market, and then the travel time to get to that nearest service or market, because sometimes it could be near, but you have to cross a mountain range. So many of these sites are actually considered frontier, which is even more rural than rural. So I don't have it's based on all of those, and then they put it into a formula, but I could certainly, share that information. But most of the state, because we just hit 1 million people in the whole state, so most of the state is rural, and I would even argue that most of Yellowstone County is rural, but we're considered the booming metropolis. So in Billings. In terms of the notification, the trigger is a discharge. So when the discharging provider signs off on the order or puts in the order to discharge, that triggers the notification to be sent automatically to the PCP listed, and that gathers all the information that's been entered. And there was a follow-up question to that on, what about the information that maybe is typically in the discharge summary that hasn't been entered or recorded yet? But all of the information on the notification has to have been done by the time the patient's discharged, which is really just follow-up appointments, medications, and what happened to the patient. That's already been entered in there. The piece that's missing, that's been a little point of contention, sort of, is that there's no discharge diagnosis on the notification because it's triggered before that's put in. But the providers are referred to the provider portal, so they can get directly into our whole system and find out the discharge diagnosis there. But providers have asked they would like that to be included, but the timing isn't quite right to do that. So I hope that answers those questions.
Great, thank you. Just another question for you. I see you are having a discussion through the chat about family caregivers, and someone asked whether they are engaged at all. If you want to just give a little detail to the participants on the phone about that. Yeah,
so it's a great, they should be engaged in the process. And when we did the discharge checklist, we did not engage family caregivers. We used the staff, which I thought was better than not engaging them at all. We have since created a patient council, and we're using that patient council for just these kinds of things. I completely agree. I don't know if everyone can see the chat, but the person who I was having the conversation with sent a link to a document that is by the United Hospital Fund, engaging family caregivers as partners in transitions. And maybe that can be shared. It's actually just uhfnyc.org. There's a lot more information there. So we did not, I agree we should, but we did not very much engage family caregivers, except that we did, if they were there in the room, we engaged them in the education, and when we did follow-ups with patients on the phone, we would include them if they were there or ask for their help in gathering medications and answering questions. But beyond that, that's all we did for this study.
Just to take it to a more general level, any of you can answer this. What would you do differently next time with studies like these?
Well, I think I touched on that. I would have, I definitely would have done more, laying a foundation of trying to understand more, not in general about CDS use in the literature and integrating it into, processes of care and standard operating procedures, but to really understand the particular constraints within the environment in which our providers work so that I could understand better, what might need to be tailored to a particular environment as distinct from what are the sort of core things that you would do in any environment.
Vera, this is Eric here. I think I would choose an intervention which I knew clinically worked to begin with, and I think that's a key thing for us. I think that just automating something doesn't really lead to change in patient outcomes. You have to be in a situation where what the clinician is going to do actually works, where they have the tools already, and then you're just automating that process. So I think that I would be much more careful next time and look for a situation where there was hard evidence of some kind that an intervention was working in the population of patients, and I would provide information to the clinician to allow them to automate that process.
And just to follow up with you, Dr. Eisenstein, do you think your study results would have been different if members of the network had shared the same EMR?
That's a great question. I know I gave this talk at Duke, and that was the first question that I got. I don't think so. I think it would have been better. I think if you'd have had an EHR that they would have shared, then you'd have had the information in the chart all the time. So the discharge summary would have probably been in the chart all the time. So you wouldn't have that problem. You'd be able to contact the patient either through the portal we have here or send letters to them, whatever. So things would have been tied together a little bit more neatly. But I don't think it gets back to the question, even if all the information were there, do I think the intervention would have actually reduced hospitalizations, reduced ED visits? I don't think so. So I think it would have been, things would have worked better. It might have been easier to implement. But I don't think it would have changed the results of this study.
I would add that, we've just been working on another project with a group that's really reviewed the recent literature on predictors of rehospitalization and interventions that actually reduce rehospitalization. And if you look at the literature as a whole, the predictors of rehospitalization actually predict a minuscule proportion of rehospitalization, and the rest is really unexplained variance. And the literature on interventions is really pretty mixed. And so I think, we've got 1 out of 3 projects that was, that achieved the ultimate outcome here, and I think it's sobering. This is an incredibly complex problem, and it not only reflects the actions and the interventions of the clinicians in several settings, but it's really influenced by the environment and by the patient-family nexus, and it's very sobering. And I think that electronic tools, particularly to the extent that they can really help people move toward different behaviors, which is really the purpose of CDS, have something real to contribute, but there's not a magic bullet here.
I think you're right, Penny. This is Eric again. I think if you look at the literature, it's easier to predict which patients will die as opposed to which ones will go back to the
that's
hospital.
Nice.
I mean, if you look at the ability of the statistical models, that's what the case is. And I think it's because, as you said, there's so many factors in the environment that can determine whether the patient is going to be readmitted or not.
And this is Elizabeth, I'll just add to that thread. I'm sure you've read about, hospital syndromes, so stuff that happens to you just by the fact that you're in the hospital. And some of the maybe more promising interventions are those that keep you out of the hospital to begin with. So instead of looking at readmissions, just look at admissions. And, for one example are these extensivist programs where people who normally would be admitted go to a different higher level clinic where they just stay for the day and then go home and tend to do better. Anyways, because I completely agree, and I think that there are so many factors and so many cultural things going on as well. But that's a promising idea that's relatively new. I don't know if you guys are familiar with it or not.
I think it's a good point, though. I think it's an excellent point to think about keeping the patient from going into the hospital. What can be done there?
Yeah.
You're absolutely right.
So while we're waiting to see if any other questions come in, I was wondering if any of you had questions for each other based on each other's talks.
I did. I had to get back from the philosophical to the more practical. On the first study, I just had a question of how was your baseline group selected?
So they were just patients discharged from the hospital who had at least 2 chronic conditions of those 8 that I listed, and were discharged to a rural community, so to pretty much a community outside of Yellowstone County. So it was pretty inclusive, and then we randomly selected from those groups. So we had a limitation of how many patients we could, we called 800 patients. So we had to go with, here's the month of discharges, here's the ones that meet our criteria, how many of those can we call in a month, and then we randomized that group so that we weren't being biased. So that was the best to do unless you have better ideas.
I had a follow-on question if I could, and it relates to the fact that in our network in Duke, we have Durham County, which is basically a city, Durham City, and we have 5 rural counties. We found out that you can implement something in Durham County, you can drive out, you can see the patient. But if you're in a rural area, the care managers are really spread thin, and things are quite different there. So what are the differences if you mean with a population as a frontier group of patients, basically? So what kind of means would be different, dealing with a frontier population versus an urban population?
Well, really just geographic distance would be the main thing, as well as services. So a lot of these communities have critical access hospitals or small clinics that only provide primary care. Very little specialty care being provided. And I don't know if I'm answering your question.
You are, yeah.
Yeah. So very little, and we have lots of statistics on the lack of access to services by people living in these rural communities. And, some are 300 miles or 400 miles away from Billings, and this is where they're coming for hospitalization. So there's all kinds of factors that, add to that. So if someone's discharged, they may even have to drive 50 miles just to get to a little primary care clinic to see anybody.
Exactly.
So there's these things that add to the problem. One of the things we've been interested in is more use of telemedicine for even primary care visits or any kind of visits. And we use telemedicine a lot, mostly for specialty care, not so much for primary care. But that's something we're exploring. How can we better leverage telemedicine for follow-up?
Right. Thank you.
So I think this question is for you, Dr. Siemens, and I'm not sure if you answered it yet through the chat, but someone asked, does your organization have NCQA or URAC accreditation?
Yeah, and I did answer, but I think, did they mean for medical home? And so I'm not, I mean, we do for patients that are medical home accreditation, and I know there's some care transition measures on there, and I didn't understand the second part of the question, which said, how are caregivers and patients or the facilities notified of this? And I'm not sure if it means notified of the accreditation. Did you understand that question differently? Because I'm not sure how to answer that part.
I think I understood it the way you did.
Okay. So and that whoever chatted that could do a follow-up if they want to clarify what they're getting at with the notification piece of that.
So it seems like no other questions have come in the chat unless anyone's furiously typing away now. So just as a final reminder, to obtain CME or CNE credits, information will be sent to you via email within 48 hours with instructions on how to receive continuing education credits for today's session. And I want to thank you all very much for joining us. And if you have any questions, you can email the presenters or you can email one of us here at AHRQ. Thank you so much.
Ladies and gentlemen, that does conclude today's presentation. We'd like to thank you once again for your time today, and you may now disconnect.